And it's my pleasure to introduce to you Dinushika Mohottige, who's an MD and a faculty member of the Institute for Health Equity Research at Mount Sinai, as well as an assistant professor for population science and policy and medicine for the Mount Sinai Barbara T. Murphy Division of Nephrology. I'm so glad you're here with us today. Such an important topic that we need to talk about, which is nephrology and how it affects underserved and disadvantaged communities. So, Dr. Mohottige, what is the study of nephrology for those who don't know what that is?
Thank you. And first of all, thank you so much, Brian, for having me and highlighting this important topic. So the study of nephrology is essentially the way that we take care of kidneys and kidney function for individuals. And nephrology specifically refers to the profession within internal medicine, where some of us have specialized training in how to care for people with kidney disease across the spectrum of kidney disease.
You know, it's funny because I'm learning about all this too, right? And what the terminology is, because I think it's important for us to know, what we're talking about here. Now, specifically, I mean, you're doing a lot of work in terms of research and collecting data and analysis with the Institute for Health Equity Research at Mount Sinai. Why is it so important for us to know and understand nephrology as it relates to underserved and disadvantaged communities?
Yeah, wonderful question. So the first thing that I would say is that there are essentially 38 million individuals who are impacted by chronic kidney disease in the United States. And many individuals do not know that they have chronic kidney disease. Although there is a tremendous amount of attention on, cardiovascular disease or heart disease, on things like dementia, there has sometimes been a lack of community understanding of the linkages between cardiovascular disease, high blood pressure, diabetes, and kidney disease.
Wow.
The most common causes of kidney disease in the United States are diabetes and high blood pressure. And why this is important for minoritized populations and racial and ethnic minorities is because those two diseases disproportionately impact Black and Brown communities or communities of color. And kidney disease also disproportionately impacts people who are minoritized. And I'm going to just give you one statistic to kind of
Okay.
highlight this how serious this situation is. Although Black Americans make up 12 to 13% of the US population, they account for 35% of the population in the US who are on dialysis. And that is,
Wow.
the treatment for kidney failure, among other treatments like transplant. And one more statistic that I think can kind of highlight how serious this issue of disparities in kidney disease are is the fact that Black Americans continue to have a 2 to 3-fold higher risk of developing kidney failure versus white counterparts. And that disparity has persisted for the last over 2 decades. So we have urgency to disrupt this kind of disparity that we've been describing for so long.
Wow. That is that's incredible. That is really, really incredible. Um, again, you've been talking. I mean, this is information that we really need to know about that probably isn't out in the public sphere. And so I'm glad that you are talking about this today. Are there some other things that we need to know from long term studies about these communities specifically and kidney disease?
Yeah, so I think the few kind of important things to highlight also are that we know increasingly that the exposures that people have, or essentially the context and environments in which people live, which are impacted by structurally racist policies and unequal policies, those environments may predispose people to having chronic kidney disease. And these two linked characteristics or conditions that I mentioned, diabetes and high blood pressure. So when we think about what, beyond just being empowered with the knowledge about how this is impacting certain communities, I think we ought to be empowered with information about the kinds of policies that need to change at the community level, that can help to undo some of these disparities. So I'm specifically talking about things like access to healthy and nutritious food, access to
Mm.
places where people can walk and get meaningful physical activity in safe environments. And I'm thinking about things like housing, which we know is associated with worse outcomes. So all of these things really matter. But I think a second area of attention is really around things that people may not know in the community that can cause some harm to kidneys. For instance, high doses of medications like Motrin and ibuprofen, if you have chronic kidney disease, those meds in high doses may have an impact on kidney function. And so I think some of the ways that we can undo some of these disparities is to really get knowledge about kidney disease into the public, link it to things like high blood pressure and diabetes, and then understand how we can advocate at the community level to ensure that the environments that people live in are truly safe and health promoting.
Absolutely. I'm just like nodding and I almost want to say amen to everything that you're saying. I did some research and did some homework on some statistics myself, and it says research stated that end-stage kidney disease, that's ESKD, KD, care places a significant burden on the US healthcare system as a whole, right? But it accounts for $50.8 billion annually in Medicare expenditures, which means that with Black Americans specifically, they have over 3 times the rate of end stage kidney disease as white Americans, which means that's a lot of money and a lot of care that's going into the system, which is probably preventable, right? I mean, this is the worst of the worst. This is dialysis treatments, 8 hours, a week of dialysis and that kind of thing, something that my father had to go through. And so I'm glad that you're talking about these particular things. Um, are there some other ways that you're thinking of based upon your experience, that we can bridge the racial and ethnic gap while lowering kidney disease as a whole?
Yes, no, thank you for that, and thank you for sharing about your father. I mean, I think I just want to say that it has always been stories from people living with kidney disease that are motivating us to ask the right research questions. And I just say that again with gratitude for you sharing how kidney disease has impacted your own life and your own family. In terms of disrupting the disparities that you describe, and particularly, I think highlighting the amount of money that the U.S. healthcare system is spending on, this outcome that we all need to disrupt much earlier, which is being on dialysis or kidney failure. A couple of things. I would like to see, honestly, screening for kidney disease become part of a national conversation. And the National Kidney Foundation and other organizations have been advocating so that the U.S. Preventative Task Force will make chronic kidney disease screening potentially part of our screening guidelines. So that's the first thing in terms of awareness. The second thing is we know that there are continued disparities in who is getting access to treatments that we know can slow the burden of kidney disease. And this is absolutely critical. I think there have been now at least 3 studies that I know of that have documented how racially minoritized individuals, specifically Black, Latino individuals, are less likely to be prescribed some of these medication classes that can slow
Wow.
disease progression. So this is a key area, something that has been termed pharmacoequity, equity in pharmaceutical prescribing, that we should be paying attention to, that can ideally reduce those long-term costs of the outcome that none of us want, which is dialysis. And I think the third piece of this is taking that final step to support national efforts so that people who have developed kidney failure can have equitable access to a more ideal option, which is kidney transplantation. At this point, the disparities in kidney transplantation continue to be stark. Those same disparities that I mentioned in terms of kidney failure risk also apply to transplantation, particularly living donor transplantation, which is sort of the best case scenario, getting a kidney from a friend, family, loved one, et cetera, okay? These disparities in who gets those transplants, who is even educated about the options for transplant, we have to start to make some real progress in that arena. And I hope, there's a lot of positive policy changes that have happened in the United States around this, but we need to continue to do better and do more and have a transparent process so that people living with kidney disease can sort of understand what their options are and how to navigate that journey.
Doctor, this is personal. What you're talking about is very personal to me. I know you don't know my father's story, but it is a textbook example of the connections between cardiovascular disease and kidney disease, where my father was diagnosed with high blood pressure when he was my age. Actually, he was younger than me, like in his late 40s, early 50s. They prescribe medication for high blood pressure, but they don't tell him that the medication that he's getting is also going to ruin his kidney function long term. So as he got later in his years, in his 70s, they discovered the kidney disease that's there because of this medication. And now the only alternative is something that you just touched on, which is kidney transplantation, right? None of us are viable candidates, but there's also no education around what are all the options that are available to him early on, not later on when it gets so bad, but early on in the process. And so that's definitely something that I can totally align with you on in terms of that needs to be done. Um, while we have time, let's look into the future. Let's look into this state where possibly some of the things that you're suggesting are now available, and we're hoping and praying and have optimism that that is going to happen. What are some of the other things that we need to know when it comes to the future of nephrology from your perspective?
Mm-hmm. Yeah, wonderful question. I think a few things that have been really exciting areas where we're imagining a different future. Because my dream would be that actually there is less of a need for people like me to even practice. I would love to see us focusing on, again, prevention and early detection, diagnosis, and management. And some of what is exciting is that there have been some important discoveries about genetic risk factors that individuals have that might be accelerating their risk of kidney disease. And so understanding and having more trust so that patients can trust the health system to gather data about genetic risk factors and then ensure that that genetic information is used in a way to enhance their care, right? And to not, promote discrimination, et cetera. Finding targets for medications that can address these genetic risk factors, such as APOL1 risk alleles, which disproportionately impact individuals with self-described African ancestry. That is something I'd love to see, more advances in. The second thing that I think we need is to continue to have a conversation about insurance coverage of these medications that can slow disease progression. We still have huge disparities in terms of what individuals have access to, depending on whether they have private insurance versus Medicaid versus Medicare, and it has created essentially segregated systems of care, and that needs to be disrupted. And I think the third thing is all of the advancements in transplantation. There's a lot of excitement about, you might have heard, xenotransplantation, or using donor kidneys from pigs and other genetically modified animals to expand the pool of kidney transplants is something that's, in its early stages, but definitely something that's exciting in the nephrology community. And my hope there is, no matter what advances we have in the field, we have to center equity and patients' experiences at the core of the way that we move forward with these studies and these advances. Because if these advances are not equitably available, in 20 years, we'll just be having the same conversation. And I pray and hope more than anything that that is not where we are. We
Uh,
have to do better.
I could not agree more. Dr. Dinushika Mohottige, it is such a pleasure to meet you. Thank you for what you're doing. Thank you for the awareness that you're bringing to communities across the nation. Um, this is personal for me, and so to have you speak upon it in the way that is both heartfelt, determined, and committed is very refreshing. So thank you for being here. Thank you for bringing the necessary insight and wisdom to our communities for the betterment of all of us. So thank you again.
Thank you so much for having me and for highlighting this.